guys, hope you're all doing good. I know that you have been really preparing well and you are ready to kickstart your like last minute revisions for your upcoming Part 1 MRCOG exams. So here we bring the RRR series. Thank you so much for so much of love and support. So this is called Read, Revise, Repeat series, and I'm going to cover the clinical management. Actually, clinical management is very huge. I have touched upon the most important flow charts so that you will be able to answer anything which comes with that. Okay. I have given more importance to the green top guidelines and the nice guidelines. Okay. So definitely your success is our goal. I hope to see all of you winning and becoming the most successful champions of this season. Let's kickstart. Guys, for your exams, it's very, very important to know a couple of things in early pregnancy module, that is the miscarriage, how to diagnose. So the point with the early pregnancy miscarriages, like how you will go about is, you will see two things. One is gestational sac and the other one is the CRL. So if you are doing it for the mean sac diameter, if it is less than 25 or more than 25, okay? So when you do a transabdominal scan and there is no visible fetal pole, so and the diameter is less than 25 millimeter, if it is transabdominal, you would definitely going to repeat the scan after 7 days. If it is transvaginal, you are going to repeat after the scan after 7 days. Remember, abdomen 14, transvaginal 7. However, what to do if the diameter is 25 or more, only sac is there and no visible fetal pole? In that case, you have got two options. Either you can repeat the scan after 1 week if it is TVS, or you can take a second opinion now and do both. For example, somebody comes to you probably like 7 weeks before she had got her last menstrual period, and you see that the gestational sac diameter is 27, but there is no visible fetal pole. Then you can do one thing. You can send a second opinion now, or repeat a scan after 1 week, or you can do both. Okay, because you need to be double cautious before you diagnose the miscarriage. That is the reason. And what would you do if there is a fetal pole, but there is no cardiac activity? So what is the cutoff you take? It is all about 7 millimeter. So when you do 7 millimeter, when you do a scan, there is a fetal pole, which is less than 7 millimeter, but absent fetal heart rate, you repeat after 7 days. However, if it is 7 or more and fetal heart sound is absent, you take second opinion and probably the second one you will be doing scan after 7 days. And obviously the same thing holds good for transabdominal, which you do after 14 days. So remember 25 and 7, 25 for gestational sac, 7 is the cutoff for CRL. And obviously for transvaginal scan, you would tend to repeat after 7 days. For abdominal, it's always after 14 days. Now, a couple of scenarios, very easy and straightforward. 6 weeks, a preemie comes and you do a transabdominal scan, gestational sac of 23. As discussed, less than 25, because it's abdominal scan, you repeat scan after 2 weeks. The next one, you do a multiparas TVS, sac of 24. Again, less than 25. So you repeat scan after 7 days. We are talking about the gestational sacs here. The next one, there is a multiparas, undergone TVS, sac of 27. So 25 or more. It is a second protocol which we discussed. No visible fetal pole. Then you can send for second opinion and our second scan of 7 days because it is transvaginal. The next one, there is a gestational sac of 27 millimeter with no visible fetal pole. 2 people have checked the scan, then you diagnose miscarriage. The whole point is you have to give a benefit of doubt and make sure that you give sufficient time before you diagnose miscarriage. Okay, guys, you will be asked questions on this. That's the reason I've given you this. Now, if already miscarriage is there, how would you go about the management? The first and the foremost thing is you have 3 types of management. Expectant, that is asking the nature to take care. The next thing would be the medical, by giving misoprostol and mifepristone and taking from there, or the surgical management. Let's talk about what would you do if the nature has to take care. Generally, what you would be doing is you will ask the woman to wait for 1 to 2 weeks. In that case, if she bleeds and if she's she has completed the process in 1 to 2 weeks, the bleeding stops, Still, very important step, you have to repeat a pregnancy test after 3 weeks. This is very important because you want to make sure that there is no element of molar pregnancy. However, if it doesn't settle down or if the bleeding doesn't stop at all, next you do repeat a scan and discuss the further options. So remember, expectant management, 1 to 2 weeks you can wait. If it doesn't happen, you can go for the next set of management. What about the medical management? There is a recent updated guidelines which talks about giving mifepristone to missed miscarriage because it can help in better cervical priming. So you can use for missed miscarriage misoprostol and mifi, and for incomplete miscarriage you can use the misoprostol of 600 microgram. The dose is important. Misoprostol 800 here it is 600. And what else you do? Once you complete the process, again, remember 3 weeks after medical management. This is the very important question because expectant or medical, you are supposed to be doing a pregnancy test after 3 weeks. Okay. Now, something about the tubal ectopic. Okay. Tubal ectopic, you must remember about when to do what management. These are the hormone cutoffs, expectant less than 1500. And for expectant and medical, the most important thing is fetal heart sound should be absent. And they should be ready to come for follow-up because you have a frequent follow-ups. And for medical, when you give methotrexate, you know it is a reversible inhibitor of dihydrofolate reductase. You should make sure that there is no intrauterine pregnancy. Okay. And the hormone cutoffs, you can see beta HCG and adnexal mass. Very, very important. Irrespective of this, if somebody is presenting with pain and significant pain, hemodynamic instability, the next best management would be, irrespective of the size and the adnexal mass, the laparoscopy. That is the gold standard. Now, when do you choose salpingotomy, salpingectomy? We will be looking into the next scenario, next slide. However, if the fetal heart sound is present, that is the indication to go for surgery, because once the fetal heart sound is there, the multiplying cytotrophoblast is so many, you cannot stop either with expectant or the medical. Okay, so let's move on. And a couple of things about the first trimester screening. Remember, for the downs, all these are including the first trimester screening, second trimester screening, there is a detection rate and they are all screening tests, which tells that, okay, 1 in 150, like 1 in 100, 1 in 20, the possibility of baby having the downs. And what are the tests? Between 11 to 13+6, it is nuchal translucency, the fluid behind the nape of the neck which you measures. Generally, it has to be 2.5. Okay, if it is more than that, you need to be worried. Free beta HCG and PAPA you will be checking. These are the two blood markers and as well as the scan. Or else you can do cell-free fetal DNA after 10 weeks. Remember, cell-free fetal DNA is a screening test for downs. In second trimester, you have quadruple test, which talks about alpha fetoprotein, beta HCG, unconjugated in estriol and inhibin. So to understand what rises and what falls in the second trimester, because it has 4 components in quadruple, just remember whichever has a component of H in their names, that is increased. Like beta HCG has got H, so it would be high. Inhibin has got H, so that would be high. So 2 high and 2 low. So beta HCG, inhibin would be high, PAPA and AFP would be low, just for your understanding. Okay. Next, when you do the screening test, you need to explain to them what is the best screening methods, what is the detection rate, what is the false positive. It's quite easy. You can see all the false positive is, for all the tests, it is 5% except cell-free fetal DNA, which is 0.1. And when you move to the other side, you can see that, you can see here that they increase by 5. Okay, double test, triple test, everything, there is only 5 increase. The most important and the best test could be first trimester combined test, which has 90% detection rate, and cell-free fetal DNA 99%. And how do you confirm that somebody has got, the baby has got Downs? The needle test, that is a chorionic villus sampling, which is done from 11 to 13+6, or which is taking a bit of a placenta. Amniocentesis is taking a fluid around the baby and testing. And remember, you need to know the percentage of miscarriage because they have been asked this. So it's around 0.5% if at all it is a well-trained one. For the CVS as well as for the amniocentesis, it is 0.5% miscarriage rate. A word about molar pregnancy. So just to tell you guys, complete molar pregnancy is diploid, incomplete is triploid, and incomplete or partial has got baby because there is a contribution from the mother as well. And generally incomplete is two sets of paternal and one set of maternal would be there. Okay, so that's why it is triploid. And you can see the fetal parts here. Unlike the complete where it is single sperm, either it is a duplication of single sperm with empty ovum or dispermic fertilization of an empty ovum. Okay, so mostly the sperm multiplies and that becomes a complete mole, or two sperm fertilizing an empty ovum. Both of them, the management is only surgical suction evacuation. However, if incomplete, if the baby is little bigger because you cannot suck it, the fetal parts, you have to start out the process of labor and then do a suction evacuation. Chemotherapy, complete is at a higher rate, 13 to 16%. Like people going for choriocarcinoma is more incomplete rather than partial, where it is 0.5 to 1%. In other ways, you can think that partial, because baby is there, it is more protective against development of cancer. Now you can see snowstorm appearance. This is a complete one. And this is the partial one where you can see the abdomen of the baby. Okay, so this is the snowstorm appearance. Fine. Perfect. So how do you follow up? This is important because beta HCG and urine tests are done after the molar pregnancy till it is normal. And once normal, it varies for complete and partial. Partial, as you know, the risk of choriocarcinoma is less. So you do 2 samples 4 weeks apart. Once negative, they are discharged from the follow-up. Unlike the complete molar, where you would be doing till it becomes normal, generally, it becomes normal within 56 days or 8 weeks. If it becomes normal within 8 weeks from the date of evacuation, for example, if they have got evacuation in the month of January, from there till the 6 months, they would be doing. Okay. So 6 months from the date of evacuation, if it becomes within normal in 8 weeks. That means if somebody has undergone evacuation in the month of Jan and it becomes normal by end of February, then you would be going on and doing the follow-up till June. Okay. However, if beta HCG is taking more than 8 weeks, that is, if somebody has done an evacuation in Jan and it is becoming normal in April, from April, you do for the next 6 months because you don't want to miss on the development of choriocarcinoma. That's the main thing. Okay. So you guys need to know a bit about a follow-up. So that's what I have put it here. Okay. If it doesn't become normal, then you would be going on till the date of, from the date of normalization, you will be doing 6 months. Perfect. And you need not know about the complete prognostic scoring, but you need to know the components. And remember, total score of 6 or less, 100% you will be having a success rate. This is about the GTN, gestational trophoblastic neoplasia. Once you calculate the score less than 6, it's always a single chemotherapy methotrexate. If it is 7 or more, you go for multiple agent chemotherapy like IMACO regimen. Obviously, there are different varieties. If it is PTSD, then they're less chemosensitive and you have to go for hysterectomy. Don't worry, this is a little advanced knowledge, but this one, you guys need to know a bit about it. Now, when to stop what? This is very important. You guys would be asked questions on prophylactic and therapeutic. Prophylactic 12 hours before, therapeutic 24 hours before. After spinal or epidural is removed, you have to wait for 4 hours and then start. Prophylactic unfractionated heparin, you can start 4 hours before. Therapeutic, if depends on the route, IV 6 hours before and subcutaneous 12 hours before. Guys, this you need to know. A bit about the thromboprophylaxis chart. So you guys need to know what are the high risk, what are the intermediate risk, and what are the minor risk. So if it is high risk, somebody who definitely needs antenatal and postpartum. One thing you must remember, if it is somebody has received antenatal throughout, then postpartum 6 weeks, automatically they have to receive. And intermediate risk, like it depends on the scoring. So if it is 3 risk, intermediate risk, you usually start considering from 28 weeks onwards, 28 weeks and 6 weeks postpartum. But it is minor factors. You have to have 4 factors. This 4 risk factors. For example, somebody who is a 37-year-old, fourth gravida, who is a smoker, who has multiple pregnancy. So you have 4 risk factors. Then you start from first trimester itself. If there is somebody who is a smoker with gross varicose veins and she's current preeclampsia, you start from 28 weeks. So these minor risk factors, 4 from first trimester, 3 from 28 weeks. However, if it is less than 3 factors, if there are 1 or 2 risk factors, you advise them to have mobilization, hydration, and things like that. When you come to the postnatal, actually the number of risk factors, what you consider is less because they are more prone for VT risk in the postpartum. For example, high risk, you would give 6 weeks and again assess whether it is required to continue. Intermediate risk, you would be giving, initially it was 7 days, now you give 10 days of prophylaxis. And here, if somebody has 2 or more, okay, you have to be giving 10 days. Here it was 3 to start with. Here 2 or more, you start off and give 10 days and assess again. Less than 2, early mobilization and hydration. Guys, you need to know this because sometimes they will ask you to score and also give the management options. It's easy. Just go through this start once. And the doses. Sometimes they could ask you the doses. Just remember to this side where it is 40 differences there and this is 20. Enoxaparin, you have to remember it is only 20 differences there. And deltaparin, it is double the dose. Okay, tinzaparin is unique. You have to remember. If they ask you the dose, they generally ask you these 3 only. So you need to know about it. Now, that was prevention. What to do? Somebody comes with a suspected pulmonary embolism. Generally, the first thing what you do is clinical assessment, chest X-ray, ECG, then full blood count, because you have to make sure that you have to start these medications, urea electrolytes, LFTs. And somebody comes with breathlessness and suspected pulmonary embolism, you always look for signs of DVT. If it is there, you do compression duplex ultrasound first. And if that confirms that there is a DVT, no need to check for pulmonary embolism, you start therapeutic dose. However, if you are not suspecting DVT, then you take a chest X-ray. If the chest X-ray is normal or abnormal, if the chest X-ray is normal, you do a VQ scan. Only thing, ventilation perfusion scan, you have to explain the risk of, little bit increased risk of childhood leukemias for the baby. You have to explain to that. If the X-ray has got some abnormalities like atelectasis, pneumonia, consolidation, you go for CTPA. Whenever you do a CTPA, because it's a high dose radiation which the maternal breast get, you have to always explain the little bit background increased risk of breast cancer. Either the ways this is confirmed, you would be continuing the therapeutic doses. If it is not confirmed, then you will look into what is your clinical suspicion. If it is low, you discontinue and again repeat the things or go for alternative like MRI angiography. If the suspicion is high, you won't stop the medication. You would continue the anticoagulation and think of alternative, probably to repeat the test later on. Okay, this is important, guys. They would be asking you this. Now, very important flowchart for placenta previa accreta spectrum. One thing, antepartum hemorrhage, it could be abruption, it could be vasa previa, it could be placenta accreta spectrum. So you call low-lying placenta when it is less than 20 millimeter. Okay. Whenever you have a doubt, you always do a transvaginal scan, especially posterior placenta or a high BMI. In the history, if they have a previous cesarean section and placenta previa, you should always rule out placenta accreta spectrum. Okay. And if you have a suspicion, you can go for MRI. If that is not the case, you see placenta, like low-lying placenta or placenta previa with its anterior or posterior. In the earlier gestation, you repeat TVS at 32 weeks. This is an important SBA, guys. At 32 weeks, you would repeat the scan. And if it is confirmed placenta previa, if somebody is asymptomatic, okay, she has a low placenta previa, but she is asymptomatic, then you give a steroids at 34 to 36 and try to deliver them by 36. Somebody is having a like minimal spotting, but it keeps on happening, recurring, then you will have to give steroids before 34 weeks and deliver them little preterm by 34 to 36. Asymptomatic low-lying placenta, I'm talking about low-lying placenta. What you do is, after like 32 weeks, you have seen it's a low-lying placenta, but it is not previa. You would repeat a scan again at 36 weeks and see if the baby's head has, like, for example, if there is a placenta and it is baby's head, if the baby's head goes below, okay, so then you can deliver. Obviously, that would be a consultant decision. But in 32 weeks, if placenta is 20 millimeter or more, you discharge from the follow for this particular reason. Once the placenta migrates 20 or more, it is no more low-lying or the placenta previa. Obviously, if there is a placenta accreta spectrum, you have to make sure that she delivers in all the tertiary unit with anesthetist and blood bank and the consultant and things like that. Okay, guys? Now, very important and a simple labor and labor module, which talks about the progress. How do you suspect delay in first stage? Okay, actually, delay in first stage, you will be thinking once they enter the active phase of labor, that is more than 4 centimeters. The thing is, the current labor care guide mentions 5 centimeters as the cutoff, but you can still consider majority of the time it is 4 centimeters beyond which they would be considering as active labor. Obviously, if there is a suspected delay, the frequency of the vaginal examination is 4 hours in the first stage of the labor. So if it is less than 2 centimeters in 4 hours, when you suspect a delay, if the membranes are intact, you do a ARM or an amniotomy, which releases the natural prostaglandins. And once the amniotomy is done, you repeat the examination after 2 hours, okay, to see how well she is progressing. If she is less than 1 centimeters per 2 hours, you have to think of multiple causes and start with oxytocin. Once you start oxytocin, you have to titrate and keep the contractions maximum up to 5, not beyond that. And once you start oxytocin, you assess in 4 hours. The point is, when you do an amniotomy, you assess in 2 hours. When you give oxytocin, you assess in 4 hours. The reason being, the amniotomy is the natural release of the prostaglandins. You can't titrate. But with oxytocin, you can definitely titrate the dose and get the contractions on board. That's the reason 2 and 4 hours. And if it is less than 2 centimeters in 4 hours in a multiparous lady, always think of malpositions and CPDs, and probably she might need a cesarean section or at that point of time, and you have to discuss with the consultant. Okay. Obviously, instrumental delivery or cesarean section, it depends upon the consultant decision. Now, a couple of things. One is what is the second stage of labor? We spoke about first stage, now the second stage. Second stage is fully dilated to till the delivery, baby is delivered. For a primigravida or a nulliparous, the maximum 2 hours of active and passive pushing the baby has to be out if they are not on epidural. For multiparous, it is 1 hour of pushing. However, if somebody is in epidural, you have to add 1 hour. No analgesia, 2 hours and 1 hour. With analgesia, that is epidural, 2 plus 1 and 1 plus 1. Okay. If by then, if they don't deliver, looking into all other things, you might have to go for an instrumental delivery. Again, assisted vaginal delivery, you guys need to know the classification. When, what, and how you call. Obviously, you need to remember for application of this delivery, like a forceps or vacuum, you need to know that the baby should be like less than 1/5 palpable, absent membranes, and like you have to inform your consultant and pediatrician and everybody. So what are the indication? Either the mother is tired or the baby is tired. Okay. And obviously inadequate progress, as I mentioned, like 2 plus 1 and 1 plus 1. Remember that. And you can help them to cut short in cardiac diseases where they have an NYHS score of a class of 3 or 4, things like that. But where you don't want to apply is fetal bleeding disorders are extremely preterm. Before they used to say about for the vacuum, like it was, the caution was up to less than 36, but they say that less than 32 completely contraindicated, and between 32 to 36 you have to be cautious because of the fetal scalp trauma. Obviously, you would want to avoid before full dilatation of the cervix, but if it is emergency card prolapse, that decisions would be done by the consultant. And you need to be taking paired cardboard gas samples. So you really need to know these indications as well. So this is what I was trying to tell you. Scalp and skull, like where it is. For example, for outlet, fetal skull or the head is visible without separating the labia, and she is either the baby is tired, the CTG shows baby has hypoxia, mother is tired, she has finished pushing, then you can go for outlet forceps. Okay, and you can do it in labor room. If it is low forceps, it is not on perineum, 2 centimeters below spine or 3 centimeters below spine. If it is a rotational one, you take it in the theater. Otherwise, you can do it in the labor room. Mid cavities, if it is difficult rotational, you have to go to the theater. Otherwise, some scenarios you can do it in the labor room also. Guys, I just want to ask you guys to watch RRR series of the labor and delivery as well, because that would help you to cover the CTG thing as well. Just to give you, if somebody is really interested to learn the whole of the CTG, you can go through that. Now, rashes in pregnancy. So there are very important few things. Intrahepatic cholestasis of the pregnancy, which has a greater morbidity for the baby and the mother. There could be risk of stillbirth, PPH, and all the things. And there are no rashes in this. They will have severe itching, but no rashes. Atopic eruption of the pregnancy, they say typical of E type of rashes, and they have a family history of atopy, which can be treated symptomatically. Polymorphic eruption of the pregnancy, very important, they have periumbilical sparing, and it is seen in any overdistension like polyhydramnios, twins pregnancy, it is seen. It can be treated again with symptomatically you can treat. And when you come to the pemphigoid gestationis, it is usually seen with autoimmune diseases, and obviously steroids could be the best bet. But in pemphigoid gestationis, they have throughout the body, unlike the PEP, which has a periumbilical, this one, okay? Now, a word about FGM, okay? Female genital mutilation. Of course, there are 4 types of FGM. It is not actually, it is a cultural thing in many of the countries. And if you see a lady with FGM, you have to do additional screening for hepatitis C, and you have to do a recording and reporting so that the data gets data gets finalized, because generally only once their name would be put, rest of the time it is anonymized data. And one thing you have to be telling, for if they have a type 3 where it is completely closed, you would be cutting open the scar tissue, which is called de-infibulation. That is allowed, but you won't be restitching back to the same thing, which is re-infibulation. De-infibulation is definitely not allowed, and it is illegal to get it done in UK. You can see these are the different types of FGM. So this is the type 3. De-fibrillation means cutting open the scar tissue, but it would never be restitched back like this, because it is important to remember that the mother with the FGM mother would be monitored as well to make sure that the baby is taken care. And also, you need to remember, any teenager with FGM comes, you have to report to the police within one month. Okay, within 1 month, you have to report to the police as well. And obviously, they would be taken care. They would be seen whether the mother has a thought of getting it done for the child. So all that definitely you need to be doing. And this cutting open the scar tissue, which we call de-infibulation, it is done from 20 weeks till the first stage of the labor. This can be done. Okay, guys, I'm only covering the important and the crisp points so that it would be easy for you guys. So once she comes in antenatal, safeguarding risk assessment to see whether she wants to get it done for the baby or not, you would be doing, and you have to explain the law. If somebody helps in getting done for the baby, it is illegal. Sometimes it could be so vigorous that there could be imprisonment of 14 years as well. So very careful. Data recording, which I mentioned, they have to be their name only once it would be put. Rest of the time it is anonymized data. And clinical management, antenatal, intrapartum, postpartum. Antenatal, as I said, hepatitis C, and 20 weeks onwards you can offer de-infibulation. Intrapartum, they have to deliver in consultant-led care. And postpartum, they would be seen whether how is the baby and whether they are trying to get it for the child and things like that. Okay. And of course, whether she needs any psychological support also, you need to do. Perineal tears, very, very important. You need to know the degree of perineal tear. If it is less than 50% of external anal sphincter, it is 3A. Equal to or more than 50%. Okay, if it is 50%, it would be grade 3B. More than 50% also 3B. 3C is both internal and external anal sphincter. 4th degree, if at all, if it includes the anal epithelium. Okay, and you need to know the way actually they have been sutured. So internal anal sphincter, 20 vicral, external anal sphincter, end to end are overlapping. It depends upon the whether it is complete or the partial tear. So you guys need to know about the suture materials. Now, GBS scenarios. Okay, when to give intrapartum antibiotic prophylaxis? As you are all aware, the benzyl penicillin is the drug of choice. But if somebody develops mild allergy, you can give cefuroxime. But if somebody has a severe allergy, then you need to shift for vancomycin. So GBS has got a severe probably effect for the baby. So that is the reason this is taken care. Okay, so if somebody is in preterm labor, that's an indication to give intrapartum antibiotic prophylaxis. But if they are term, unknown carrier, not to give, it is not required. Here, invasive GBS disease, that's the first baby was diagnosed with invasive GBS, please offer. Here, they are telling Streptococcus agalactiaceae. There is a swab which shows Streptococcus agalactiaceae. Obviously, that is nothing but GBS. So, you will be going ahead and giving them as well, IAP. GBS bacteria. This is your question. You can treat with oral antibiotics now and then offer IAP. Breach going for elective CS with GBS positive. Unless the membranes are ruptured, the baby is not in trouble. So no IAP required because she's going for elective CS. If she was going for a delivery, then you have to give. And when is the ideal time to do screening? Between 35 to 37 weeks. If positive, you go ahead and give IAP. So this is the flow chart. You need to remember the preterm labor you have to offer, previous infant with GBS you have to offer. And obviously, if somebody wants to repeat the test, when to repeat. Term pre-labor rupture of the membranes, unknown, not to give, but if it is known, you have to give. Labor, if there are no risk factors, no need to give. If they have developed pyrexia, you have to give an antibiotic including GBS. And if GBS carriage is there, obviously you will give. Bacteriuria, you give, treat then in pregnancy and give IAP. Cesarean section, no need. This is what I was trying to tell you. So the one thing is preterm labor. The second thing which generally ask is GBS bacteriuria. So you guys need to know this. Fantastic. Shoulder dystocia, one of the commonest obstetric emergencies where the baby's head gets delivered, but the shoulder is stuck. So remember, the first thing is call for help and MAC robots where the mother's thighs are hyperflexed and abducted so that the baby's, the maternal pelvis moves relative position and you can release the stuck anterior shoulder. And the success rate is 90%. If that doesn't work, you can try with suprapubic pressure. Then you go for episiotomy and either deliver posterior arm or internal rotation. And you need to, if you are alone, if the midwife is alone, she can try all fours, which has a success rate of 83%. Guys, you need to know the percentages as well here, the brachial plexus injury, fracture of humerus, because sometimes they might ask. And you need to know the protocols. Fantastic. Antihypertensives. What are the antihypertensives which you generally use? Labetalol is one of the commonest antenatally used antihypertensive, but because it's alpha plus beta blocker, it is contraindicated in asthma. The next which is used is nifedipine, and methyl dopa can be used in antenatal part of the antenatal period. When you come to postpartum, ACE inhibitor is the drug of choice, except in Africo-Caribbean, because this enzyme doesn't work well with them. So in them, calcium channel blockers is the first choice. Obviously, you need to know the definitions, which I haven't covered here. That's the basic, which you guys already know. And what to give when. So severe hypertension, labetalol, nifedipine, hydralazine you can give one after the other. During breastfeeding, ACE inhibitor is the best if she's not from Africo-Caribbean, or you can go for this one, the nifedipine, amlodipine in those races. And you have to avoid diuretics or angiotensin receptor blockers. Now, anticonvulsants, obviously, if somebody is having an impending eclampsia like clonus, headache, blurring of vision, epigastric pain, you give magnesium sulfate, and it's always like 4 gram loading dose and followed by IV infusion of 1 gram per hour. If it is recurrent, you will go for 2 to 4 gram. You can repeat the dose. Obviously, you need to know, you have to monitor the urine output, respiratory rate, and deep tendon reflexes, and you need to know the levels. The first thing which goes is deep tendon reflex, right? And you have to be careful because they are more prone for respiratory depression. If that happens, the antidote is 10 ml of 10% calcium gluconate. Okay. Hyperemesis. One of the very commonly seen thing, you have to remember, you will be assessing from PUQE score. The maximum is around 24. So you will be doing an ambulatory care if they are okay, that is score of 13 or above, but no complications. You can give hydration, antiemetics, and thiamine. But if somebody is already irrespective of the score, they are dehydrated and nothing is working, you go for inpatient management where VT prophylaxis should be given. Remember, hyperemesis has a score of 3. With dehydration, it becomes 4. So you have to start during the hospital admission. And steroids are the last mode of like last antiemetics which you would be giving. So I hope you all remember how to remember the antiemetics. The first one, everything start with zymes, the antipsychotics, which you can call chlorpromazine, chlorcorporazine, all those things. And the next line is metoclopramide, ondansetron, or domperidone. And the third line is corticosteroids. Okay, so you need to remember them as well because they can ask questions on that. Next is what to do in all these things. Okay, I'll just tell you the keywords here. Okay, somebody who is presenting at 32, BP 150-100, headache, blurring of vision, vomiting, dipstick urine, protein 4 plus, hyperreflexia. So she is purely a case of impending case of eclampsia. She might throw fit anytime. Obviously, you start with magnesium sulfate. You will be starting antihypertensives also, but the first thing you need to start is magnesium sulfate. The next one is she is here for booking hypertensive, taking lisinopril, AC inhibitor, and urinary pregnancy test is positive. What is the advice? Obviously, you have to stop the AC inhibitor because it has problems. It can cause congenital anomalies for the baby like the kidney problems. So you have to stop and start her on safer antihypertensives. The next one. Quickest and most convenient method to quantify her proteinuria, spot PCR. We know that once spot PCR is there, then no need to go for 24 hours. The next one, where you have a multiparas, 20 weeks, blood pressure 155 by 105. Before it was 150 by 100, protein 1 plus, PCR is 35, 24 hour 0.35. Obviously, what is considered most likely for diagnosis? What is this diagnosis is? Because at booking only she had hypertension, now there is superimposed pre-eclampsia, you can see with the spot PCR. These are the questions which they could be asking you from the management to the diagnosis. Hope you're all enjoying, guys. Let's move on. So what to give when? In case of APH or PPH, in case of emergency, you give O negative, Kel negative blood so that the sensitization to C antigen could be less. If coagulation profile, like prothrombin time is more than 1.5 and the bleeding is ongoing, you have to give fresh frozen plasma, right? And if you do not get the coagulation profile, but already 4 units of blood given, bleeding is ongoing, you don't wait for coagulation profile, still you start with fresh frozen plasma. Fibrinogen less than 2 gram, please start with cryo. And what are the use of giving all this? Packed red, basically, of course, blood loss you are giving, but indirectly they are increasing the oxygen carrying capacity. Platelet, major PPH you have to be giving. Fresh frozen plasma when there is coagulation profile is prolonged. And this increases the coagulation factors. And cryo you give when there is a less fibrinogen. Along with fibrinogen, it adds 8, 13, and 1 Willebrand factor as well. With a massive blood transfusion, the calcium gets reduced and there is always a risk of hyperkalemia. So you have to be after the massive blood transfusion, the anesthetist will be giving calcium IV as well. Okay. Target levels to maintain in GDM. Whoever has been diagnosed with type 1 or type 2, these are the target levels. FBS 5.6, 1 are 7.8, 2 are 6.4. Just remember millimole, that would serve your purpose. Okay. And PPROM, the most important thing is sterile speculum examination is the diagnostic one. If you don't see the LICA, you can go for the test like IGF-BP or the amnion in the vaginal fluid. And you start with erythromycin, okay? And make sure if she's, if at all, if she's allergic, you can go for the penicillin. Steroids, you will be giving between them. Magnesium sulfate, if she's going to deliver, then you think of offering magnesium sulfate, especially less than 29 plus 6. Very, very important. Unlike before, for PPROM, you can wait up to 37 weeks. Unless she's not developing any complications, obviously you have to wait for her, like you have to do the temperature, if you're sending her home and the swabs and the CRP, all that is, you should be knowing. The reduced fetal movements. One of the very important thing, if somebody comes with the reduced fetal movements, the first thing, please use Doppler to check the fetal heart rate. If it is not there, then you go for ultrasound. If it is there, then you can go for CTG. Obviously, based on the rest of the things, whether baby is alive or not, you will take care of the rest of the things. This is very important step. Okay, that's the first step which you will be doing. Red cell antibodies, the cutoffs, guys. Anti-D, see, ideally, none of these red cell antibodies should be noted if it is seen. Threshold levels for which referral. Anti-D is 4, anti-C is 7.5, anti-K, if you see at any level, because it causes fetal anemia, you have to be sending. And generally, red cell and antibody testing are done at booking and again at 28 weeks. Once it crosses this level, you need to be doing every 4 weeks till 28 weeks. Okay, and then you will be starting to start to do weekly afterwards, and you need to be referring them to fetal medicine unit where they check MCA, middle cerebral artery, PSV, to see whether the baby has got anemia. Based on that, they would be giving in utero transfusions. What about OHSS? Please remember, this is the culprit, okay, which can cause the OHSS. OHSS is more seen obviously with the PCOS, and because when you offer ovulation induction drug, early is within 7 days, late is more than 10 days, and people who are at risk is PCOS, and the other one, women with increased AMH. Okay, and this is the culprit, VEGF. Okay, that's the factor which causes. There are different types: mild, moderate, severe, critical. Always think of VT risk assessment for them. And these are the categories: mild size, moderate when they start with 8 to 12 cc, but nausea and vomiting, they would be added up, and ascites in ultrasound. In severe, there is ascites and more than 12 cc. They start getting that hematocrit starts raising, dehydrated, electrolyte imbalance. Critical, tense ascites. Obviously, hematocrit increases, oligoanuria, ARDS, kidney failures. It could be really severe. For mild and moderate, you can use outpatient management. No NSAIDs, that's important. And you need to be making sure the low molecular weight heparin wherever required. Severe and critical is always inpatient. Multidisciplinary team and definitely you have to be taking care of the electrolyte imbalance and VT prophylaxis and things like that. Okay. So OHSS is, again, you guys need to know how to diagnose in ultrasound as well. PMS, premenstrual syndrome. The point is, the culprit here is the hormone changes which happens in and around the ovulation and throughout the menstrual cycle. So if you want to treat somebody PMS, the best bet is to stop ovulation. So what are the different lines? First line, you start with exercise, cognitive therapy, vitamin B6. Then you start with combined new generation OC pills, or you can give SSRIs to elevate their mood. If they are not better, this can be given by GP. The second line is with the specialist, estradiol patches or micronized progesterone or LNGs, or you can give SSRIs, which releases the happy hormones and help them to deal better. And if that doesn't work, to understand, because people do ask to remove their ovaries as well. So you need to remember before that you give a trial of GnRH and log, which switches off the ovaries. So if she's very good with that, then you can go for surgical management. But remember, when you give GnRH, you have to add back HRT as well. Perfect. Ovarian masses, very simple and easy. Premenopausal women, less than 5, nothing to be done. 5 to 7 annual follow-up. More than 7, obviously, you will need to do further imaging at the surgery. Further imaging would be the MRI. And if you want to do the surgery, the best would be laparoscopic cystectomy. You always try to salvage the ovary. But if you suspect malignancy, then the laparotomy would come into the picture. You guys need to know the B rule and the M rule. And less than 40 years, any premenopausal ovarian cyst which is bigger, you need to be doing LDH and alpha-fetoprotein and beta-HCG and CA, including CA125. And you guys hopefully should know the calculation of RMI index, because that itself is a question. Okay. You need to know the 5 ultrasound features, CA125 and menopausal status, what they ask about. Okay. Now, postmenopausal. More than 1 centimeter only, you will be considering this as ovarian cyst. If you see ovarian cyst, measure CA125 first and TVS with or without transabdominal scan. And these are the you calculate the RMI. Less than 200, probably less chance. So you will look into what type of cyst it is. Asymptomatic, simple, less than 5 centimeters, and no other problems. You can go for a conservative management. Like you can repeat it 4 to 6 months. And again, you have to look into if it is unchanged, you can repeat again 4 to 6 months and think of going for surgery. If they have any problem, symptomatic, multiloculated, solid components, anything you see, you go for salpingo-oophorectomy. RMI more than 200, you have to do a CT scan because they are at a higher risk of having malignancy. So you will do an MDT review, and based on that, the place and the who will be doing will be decided. Okay. So more than 200, think of malignancy. Less than 200, look into the features. If it is benign one, you can wait, repeat 4 to 6 months. And based on that, persistent, enlarged, whatever, based on that, you would take your next call. Okay. I'm just taking you through the flow charts because the rest of the things you guys know very well. Vulval disorders, one of the hot topics. Lichen sclerosis, which is a cigarette paper and parchment-like. This is a very, very common pre-malignant condition which can cause the cancer. Lichen planus, violaceous papules, and usually it can be seen all over the body as well. Psoriasis, obviously, they can have other features of the psoriasis as well, silver staining, Cobner's phenomenon, all those things. Simplex chronicus, discolored epithelium, there will be a leathery appearance and chronic scratching would be there. Okay. Now, urogynecology, I think the charts you know to interpret as you are very well versed with data interpretation. I'm only talking about the management. For an overactive bladder, where the woman complains of leak once the bladder is full, the first thing is bladder training. You will be sending to physiotherapists where can train a bladder to hold the urine for longer time for 6 weeks. And like you will be, the training is for 6 weeks. You ask the woman to get trained to hold the urine for a little longer than what she can. And the anticholinergics, there are 3 drugs which you can use: oxybutynin, tolterodine, and darifenacin. Now, mirabegron, they have been added. Mirabegron, only contraindication is uncontrolled hypertension. And for the anticholinergics, if they have a glaucomas, you should be careful. And general contraindication for anticholinergics, if somebody is too old, you want to avoid oxybutynin because they are lipophilic and crosses the blood-brain barrier. And with somebody with this, if they are not better, you go for urodynamic study. And after that, you take an MDT opinion and you can give botulinum toxin A. Generally, that is through the cystoscope. You inject 100 units into the multiple sites. If she is not better, then you can give 200, but you start with 100. If somebody is not better with that, then you can give pre-sacral nerve stimulation, where an electrode is placed near the sacrum and it helps to control the stimulations for the bladder. And if that is also not better, augmentation cystoplasty. So these are the various management options. When it comes to SUI, you always see the problem with SUI is during the periods of coughing, laughing, there is a leak. So you do first is supervised pelvic floor muscle physiotherapy or treatment, which is for 12 weeks. If not better, you go for surgery. But before surgery, you need to do a urodynamic study again. And Birch Calper suspension so that urethra gets elevated. If that is not better, you can go for intramural bulking agents. You inject the agents around the urethra so that it gets swollen up and try to elevate the urethra. Or the dualoxetine is the second line of pharmacological treatment. Artificial sphincter, now the meshes are in back, okay? Like the TVT, TOT, you can do. However, they have to understand the problem with the mesh erosion. Endometrial hyperplasia. Guys, endometrial hyperplasia with atypia, without atypia. With atypia, you need to remember the biopsy is done at 3 months, without atypia at 6 months. And LNG or ES is the best for endometrial hyperplasia. And if you are starting oral progesterone, it's only up to 6 months. And if somebody is completed the family and they are like nearing, I would say, probably if they have completed family with atypical hyperplasia, you go for hysterectomy. If not, if they want to have a follow-up, who wants to maintain and have a fertility options, fertility issues, BMI less than 35, more than 2 consecutive, which you would be doing. And if it is more than 35, you would be doing like 6 months and then continue annually. Higher the BMI, higher probability of ovarian cancer. Unlike the atypical hyperplasia, where you go ahead and do a 6 to 12, like you do a 3 monthly twice and then repeat 6 to 12 monthly. Obviously, if they are progressing, you go for hysterectomy. Guys, I'm just simplifying this. Go through this flowchart without fail. Maternal deaths, very important. Within 42 days of termination of either the termination or delivery, if somebody dies, it is called maternal death. It could be direct, indirect. Direct due to obstetric complications. That because she's pregnant, she died. Ectopic pregnancy, chorea cancer, choriocarcinoma, preeclampsia, thrombosis, hemorrhage, those things. Indirect, she already had problems. She was already sick, cardiac disease, CNS disease, those things. Accidental, it could be accidents, bomb blasts, cyclones, whatever. Late death, late maternal death, more than 42 days. That is more than 6 weeks, but less than 1 year. Remember, anybody who died more than 1 year of delivery, they are not considered as maternal deaths. Coincidental, like domestic violence and malignancies, could be part of it. Remember, choriocarcinoma is a direct cause of death because if she was not pregnant, she wouldn't have developed that. So otherwise, the rest of the things comes under this one. And you guys need to know the viral load for HIV so that they can be decided. Less than 50 vaginal route of delivery, less than 50 vaginal delivery, 50 to 399 planned, more than 400 obviously planned cesarean section. And if they have a term rupture of membranes, try to induce as soon as possible. PPROM, you would be needing to start with the prophylaxis, with the GBS prophylaxis, and start inducing after understanding the pros and cons of the risk. And a word about emergency contraception, the best has always been the copper T, but you have to make sure the duration. If they are within 5 days of estimated day of ovulation only, you'll be able to give. And this is, usually there are no contraindication except contraindicated within 4 weeks. Then ulipristal acetate, it is avoided if there are on any enzyme inducers. And this is again one of the best thing for oral emergency contraceptive. But breastfeeding have to be avoided for 1 week. And when you come to LNG, so it is, see, here both of copper T and UPA can be given up to 120 hours of unprotected sexual intercourse. LNG is 72 hours. And there's a lot of things for LNG. The success rate might not be as good as them. And the BMI, if they are more than 26, you have to give double the dose. Okay. And if somebody has got UPA, you can't give, there's a lot of enzyme reactions which you need to remember. I mean, the drug reactions. If somebody is on antacids, you can't give UPA. If you have given LNG in the same cycle, you can't give EPA. Anyways, for part 1, if you know this, it's more than enough. So just understand the principles when to give and when not to give. Parvovirus risk of transmission, less than 15 weeks, 15 to 20, 25, term 70%. You know the slap cheek appearance, all right? So obviously this causes anemia and fetal ascites. Guys, I have tried to cover more of the important things. As I said before, please go through the labor and delivery series of RRR as well to see the CTG part of it. Because if you are really worried about the CTG, generally they do not give images, they cover on this. Obviously, you have to have an overall picture of the clinical management. I think you guys you know what it is. I have covered very crisp way all the flowcharts. Hope this was helpful. God bless, and you will all rock. Just remember to read, repeat, and revise. God bless, guys, and take care and stay blessed. Thank you so much.